Hello, we're going to start off with chapter 42, self-concept. And here are your learning objectives for this chapter. As nurses, we care for more than just the physical body. We care for the whole person, and that includes their self-concept. Self-concept or self-image is a mental picture a person holds of themselves. It's a powerful force that can either encourage personal growth or hinder recovery. A healthy self-concept supports motivation, resilience, and engagement in self-care. But when self-concept is deficient, patients may struggle to find the energy or the will to participate in their own healing. This is especially true in the face of illness, injury, trauma, aging, disability, or loss. These experiences can deeply threaten a person's sense of identity and worth. Even diagnostic testing and treatment can feel invasive, shaking a patient's confidence in their autonomy. Some patients are aware that their negative self-concept is affecting their health behaviors, may want to change, but feel lost about how to begin. Others may be unaware of the connection between their self-image and their health outcomes. So let's talk about our role as the nurse in supporting someone's self-concept. We have a unique opportunity to enhance a patient's sense of self through every interaction. This begins with sensitivity, listening for how patients speak about themselves, their bodies, and their abilities. We can reinforce positive attributes and strengths, encourage small successes in self-care, validate their feelings and experiences, create a safe space for reflection and growth. Even simple acts like calling a patient by their name, respecting their privacy, or acknowledging their efforts can help rebuild a sense of dignity and their self-worth. So ask yourself, am I helping this patient see themselves as capable, valued, and worthy of care? Because in nursing, healing begins not just with medicine, but with meaning, connection, and the restoration of their self. So let's take a deeper look at the variables that shape self-concept and how disturbances in self-concept can impact health and relationships. As you discussed in foundational theories of human development, self-concept evolves as individuals move through Maslow's hierarchy of needs. Once basic needs are met, people seek self-esteem, the need to feel good about themselves and to be valued by others, and self-actualization, the drive to reach their full potential by developing their unique capabilities. When these needs are unmet or disrupted, disturbances in their self-concept can occur. Two examples include one, identity diffusion. This is a failure to integrate childhood identifications into a cohesive adult identity. It can lead to difficulty forming stable relationships, problems with intimacy, and a fragmented sense of self. Another example is depersonalization. This is a subjective experience where a person feels disconnected from their own identity. It may involve a partial or total disruption of the ego, disorganization of self-concept, feelings of being detached from one's thoughts, body, or surroundings. And these disturbances can be triggered by illness, trauma, aging, disability, or loss. And they often surface during times of vulnerability, such as when they're in the hospital or when they receive a diagnosis. As nurses, we must be attuned to how patients express their sense of self. Every interaction is an opportunity to reinforce their self-worth, support identity formation, and help the patient navigate changes in their self-image. Figure 42-1 in your textbook illustrates the continuum of self-concept responses. It shows how individuals may fluctuate between healthy self-perception and disorganized identity. So ask yourself, am I helping this patient feel seen, valued, and capable, even in the face of illness or change? Because when we support one's self-concept, it's not just psychological, it's a foundation to healing, growth, and human dignity. So what is self-concept? It's again the foundational element of human psychology and a critical consideration in nursing care. Self concept is the collection of feelings, beliefs, and values a person holds about themselves. It influences how the individual responds to life events, manages stress, and engages in health behaviors. A strong positive self concept promotes resilience and growth, while a negative self concept can hinder recovery and motivation. Core components of the self concept include personal identity, which is who am I, body image, how do I perceive my physical self esteem, how much do I value myself, role performance, how well do I fulfill expected roles. And these components are shaped by three dimensions. One, self knowledge. Who am I? This includes basic facts like age, sex, assigned at birth, ethnicity, and occupation. Social roles and group memberships, traits and characteristics such as generous, ambitious, anxious. And this global self image influences emotional stability and coping. While some aspects are fixed, many are subjective and changeable, especially in response to life events like illness, trauma, or loss. The second dimension is self expectations, which is who do I want to be? These are shaped early in life by your role models, such as your parents, caregivers, public figures. The ideal self reflects aspirations and goals. A false self may emerge when individuals feel pressure to meet others' expectations rather than their own. Healthy self expectations support growth, and unhealthy ones can lead to internal conflict and dissatisfaction. The third dimension is self evaluation. How well do I like myself? This is the affective component of self concept, also known as self esteem. Maslow identified two types of esteem needs: self esteem, which is confidence, competence, and independence, and respect from others, recognition, appreciation, and status. Cooper Smith outlined four bases of self esteem. First, significance, feeling loved and valued; competence, performing important tasks well; and virtue, meeting moral and ethical standards; and power, influencing one's own and others' lives. A healthy self esteem leads to assertiveness, confidence, realistic expectations, and resilience. It helps individuals form secure relationships and cope with stress. Some emotional responses to self evaluation include pride, which is from positive self assessment; guilt, which are from actions misaligned with the ideal self; shame, from low global self worth. And these feelings are learned early in life and shaped by relationships with significant others. Here are a few theories that inform nursing practice related to self concept. First up, Sullivan's theory, which is children develop good me or a bad me self image based on their parental anxiety and empathy. These self appraisals can persist into adulthood. Hepla's nursing theory is positive interactions with nurturing caregivers like nurses can reshape self concept and promote healing. And Bowlby's attachment theory, which is secure attachments in early life foster accurate self perceptions and emotional stability. Insecure attachments may lead to distorted self concept and persistent challenges. As nurses, we can recognize signs of self concept disturbance, reinforce their strength, validate their emotions, support their identity development and self esteem, and use every interaction to promote dignity and growth. This is just the figure 42 1, the continuum of self concept responses from your textbook. People with a positive self concept usually have greater, more diversified self knowledge, more realistic perceptions and expectations, and a higher evaluation of themselves or higher self esteem. Whereas those with negative self concept tend to exhibit poor self knowledge, less realistic perceptions and expectations, and a lower self esteem. People with high self esteem, for example, are accustomed to being well received and successful. They're able to approach people, tasks, and new situations freely with confidence in their ability to interact and to get along with people and respond successfully to life's challenges. Self-concept is formed through a process that begins in infancy and continues throughout life, shaped by both inborn traits and social interactions. While self-concept is largely considered a social construct, contemporary research recognizes the role of temperament and other inborn tendencies, such as aggression, in shaping how individuals experience and internalize the world around them. Stages of self concept development include self awareness, which begins in infancy, as the child learns that the physical self is distinct from their environment. By 18 months, children begin to recognize themselves. Then, around 3 years, they start forming a self definition, a sense of who they are. By age 6 to 7, a more stable self concept emerges. Let's look at what are the influences on self concept. This includes caregivers who play the most influential role. If basic needs are met with warmth and low anxiety, the child develops positive feelings about themselves. Children internalize other people's attitudes, including responses to their temperament and behaviors. This forms the foundation of self concept. Their peers become the second most influential group, especially in later childhood and adolescence. Over time, individuals behave in ways that confirm their early self concept, reinforcing their identity. Zimmerman noted how loved you feel as a child is a powerful predictor of how you manage difficult situations later in life. Some conditions that foster healthy self concept include emotional warmth and acceptance, clear structure, discipline, and standards, defined roles within the family, encouragement of competence and confidence, exposure to appropriate role models, and a stimulating and responsive environment. These elements will help children meet challenges and develop a resilient, positive self image. There are two developmental theories related to self concept that help explain the formation of self concept. And each theory highlights how cognitive, emotional, and social growth contribute to the evolving sense of self. Eric's psychosocial stages is the first theory. Self-concept forms through resolving identity-related conflicts such as trust, autonomy, and identity. Piaget's cognitive development theory, which is self-concept develops as thinking matures. Children begin to understand themselves through increasing cognitive awareness. Hertz development task, which is self-concepts built by mastering age-appropriate tasks. Success in tasks boosts their confidence and identity. So nursing implications would include understanding how self-concept is formed helps us recognize the roots of self-concept disturbances, supporting patients in rebuilding their identity after an illness or trauma, and using therapeutic relationships to promote healing and growth. As future nurses, you're going to play a vital role not only in treating illness, but also in preventing trauma, especially in children. One of the most critical areas of prevention is addressing adverse childhood experiences. According to the Center for Disease Control and Prevention, adverse childhood experiences are potentially traumatic events that occur during childhood, ages 0 to 17. These might include experiencing violence, abuse, or neglect, witnessing violence in the home or the community, and having a family member attempt or die by suicide. These adverse childhood experiences also include environmental factors that undermine a child's sense of safety and stability, such as living in a house with substance misuse, mental health problems, or parental separation, incarceration, or instability. Adverse childhood experiences are strongly linked to chronic health problems, mental health illness, substance misuse in adulthood, and poor education and job outcomes. In fact, the more adverse childhood experiences a person does experience, the greater the risk for long-term physical and emotional challenges. As nurses, you can help prevent adverse childhood experiences by identifying risk factors early, supporting families with education and resources, creating safe, nurturing environments in clinical and community settings, and advocating for trauma-informed care and mental health support. Box 42-1 in your textbook outlines strategies for preventing adverse childhood experiences, and the CDC's provides excellent resources at cdc.gov/violence prevention/ACEs. So ask yourself, am I helping this child feel safe, supported, and seen? Am I recognizing the signs of trauma and responding with compassion? If we can prevent adverse childhood experiences, it's not only we're protecting childhood, but we're building their healthier future outcomes. Self-concept is dynamic. It evolves throughout life and it's shaped by a wide range of experiences. As nurses, understanding the factors that influence self-concept helps us provide holistic, compassionate care. So let's look at some key influences. First up, developmental considerations. This is the self-concept changes as people grow. Infants need nurturing environments to build a foundation of trust and self-worth. Children need freedom to explore and develop their independence. Adolescents and adults face more complex challenges, and their self-concept is shaped by identity roles and their achievements. Take a look at Table 42-1 for those developmental changes and nursing implications. Culture also plays a powerful role in shaping self-concept. Children internalize values from their parents and peers. When cultural expectations conflict, such as between family tradition and peer influences, confusion and tension may arise. Immigrant families often face cultural dissonance where children feel torn between their heritage and the dominant culture. We need to be culturally sensitive and aware of how these dynamics affect identity and self-esteem. Also, internal and external resources will affect self-concept, and it's influenced by internal strengths like humor, creativity, or resilience, and external support such as family, friends, finances, and community resources. People with positive self-concept tend to feel more connected and can access more resources. Those with negative self-concept feel isolated and struggle to seek support. Repeated failures can also lead to self-image or inadequacy, reinforcing a cycle of low self-esteem. Conversely, successes, especially within nurturing relationships, build confidence and encourage further achievement. This aligns with Sullivan's concept of the bad me, self-representation, and the importance of early validation. Also, life stressors and crises play a role. Stressors like illness, job loss, cyberbullying, or even aging can either strengthen or diminish self-concept. According to Aguilera, a person's response to crisis depends on their perception of the event, their situational supports, and their coping mechanisms. Each of these is deeply tied to self-concept. Strengthening any of these areas can help patients emerge from crisis with an enhanced self-worth. Also, aging, illness, disability, or trauma can influence. Society often values youth and physical perfection, which can marginalize older adults or those with visible illness or disability. Sudden changes in health or appearance can threaten one's identity and self-esteem. Patients may feel disconnected from their former selves, especially if they've internalized societal standards of beauty or productivity. As nurses, we have to challenge these norms and provide affirming, inclusive care that supports dignity and self-worth. A person's self-image influences their health, behavior, and recovery. This includes their personal identity, which is how the person defines themselves, their body image, which is how they perceive their physical self, their self-esteem, how much they value themselves, and their role performance, how well they can fulfill expected roles. These components are shaped by life experiences, relationships, culture, and health status. Illness, trauma, and aging or disability can severely disrupt one's self-concept, making assessment and support essential. So let's look at using the nursing process to develop a plan of care when self-concept is impacting one's health. So of course, we're going to start with assessment. You're going to begin with a general self-concept assessment. During every comprehensive evaluation, you focus on personal identity, and you can ask, how would you describe yourself? What are you proud of? That will give you personal strengths. For body image, you can ask, what do you like or dislike about your body? For self-esteem, use tools like real versus ideal self-scale to gauge discrepancies. Role performance, you could ask what roles are most important to you. Then we use the Focused Assessment Guide 42-1 to identify high risk factors and tailor your questions. That's a good tool. Be mindful of self-reporting limitations. Observe behaviors and validate responses with other sources. Then you're going to want to identify maladaptive versus adaptive responses. You're going to look for signs. So adaptive coping would look like acceptance, responsibility, and engagement. And maladaptive coping, you might see denial, dependency, withdrawal, or self-destructive behaviors. You're going to also assess socialization and communication and explore feelings of significance, competence, virtue, and power using open-ended questions. Next, you're going to turn your focus to promoting health and self-care. Use the Promoting Health 42-1 to guide patients in building a positive self-concept. You want to encourage acceptance of physical and emotional variations. You want to have goal setting and prioritization, participation in meaningful activities, and seeking help when needed. Our role as the nurse is not just as a caregiver. You are a mirror reflecting back a patient's strengths, worth, and potential. Every interaction is an opportunity to reinforce positive self-identity, support emotional healing, and help patients rediscover their value and their purpose. The next step in the nursing process is identifying and prioritizing problems related to self-concept disturbances. As nurses, our assessment of self-concept can reveal actual or potential health problems that significantly impact a patient's well-being and their recovery. These findings must be clearly communicated both verbally and in writing and become part of their permanent health record and guide interdisciplinary care. Some common diagnoses or problems in this area from the International Classification for Nursing Practice have several self-concept related diagnoses. One is negative self-image, disturbed body image, disturbed or risk for disturbed personal identity, chronic or situational low self-esteem, and impaired role performance. These nursing diagnoses or identification of problems help us frame care plans and address not just physical health, but emotional and psychological resilience. Some positive outcomes. Not all findings are negative. The International Classification for Nursing Practice also identifies positive outcomes. And some of these are characterized by acceptance of strength and limitations, confidence in their abilities, satisfaction with self-worth, desire to enhance their role performance. So you have to make an accurate distinction. When assessment data points to a self-concept issue, ask yourself, is this the problem itself? Is it the cause of another problem? Or is it a symptom of a deeper issue? This distinction is crucial because it's going to determine the goals we set and the interventions we choose. So some examples of self-concept disturbance. There's two examples I can give you from the textbook. One, disturbed body image with etiologic factors, including illness, trauma, disability, and aging. Some signs and symptoms would be that they avoid looking at or touching their body. And maybe they express distress. I don't recognize my body anymore. There are concerns about intimacy or appearance. The next example might be risk for situational low self-esteem. The etiologic factors might include sudden changes in body image, a role loss, or unrealistic expectations. Some signs and symptoms include behavioral inconsistent with values, decreased control over their environment, or lack of recognition from others. Your role as a nurse would be to identify the issues through thoughtful assessment, communicate findings clearly, collaborate with the care team, and support the patient in rebuilding a healthy self concept. This is the table from your textbook of examples of actual or potential health problems and needs related to self concept. The next step in the nursing process is planning. This is where we're going to set goals and plan interventions needed to address the patient's problems. As nurses, our goal is not only to assess and understand a patient's self concept, but help them strengthen it. That begins with outcome identification and planning. When caring for patients with self concept disturbances, our interventions should support these following core outcomes. We want the patient to describe themselves realistically, acknowledging both their strengths and areas for growth. We want them to express realistic expectations for who they want to become. We want them to verbalize acceptance of their self, even if it's simply saying, I'm okay. We want them to communicate feelings and needs effectively and comfortably. We want to nurture relationships that meet emotional needs for love and worth and have significance. We want to assume role responsibilities with confidence. This is equals their competence. We want them to live in alignment with their personal values and moral standards. This one equals their virtue. And we want them to demonstrate confidence in their ability to achieve their goals. And this is the power that we discussed earlier. Some sample outcomes for specific self-concept disturbances might be something like for patients struggling with negative self-concept, we aim to help them understand the link between their self-concept and their behavior. They would identify faulty thinking, maybe, such as unrealistic standards or distorted self-perceptions. We might want them to integrate positive self-knowledge into their self-concept. We may want them to report feeling better about themselves. These types of outcomes guide our care planning and help us measure progress. They also remind us that healing the self is just as important as healing the body. Then we're going to move to implementing the nursing interventions to support positive self-concept. Again, as nurses, we have the privilege and responsibility to support patients not only physically, but emotionally and psychologically. One of the most powerful ways we do this is by helping patients develop and maintain a positive self-concept. Before you can effectively support others, you must be comfortable with your own self-concept. Self-awareness and self-compassion are foundational to therapeutic relationships. Some key nursing strategies include helping patients identify and use personal strengths. Patients under stress often forget their past successes and inner resources. Our role is to encourage them to name their strengths, replacing negative self-talk with a positive thinking, reinforce their personal power, help them cope with necessary dependencies due to illness or aging. Ask questions like, what has helped you cope in the past, and what are you proud of? The next one would be supporting at-risk patients to maintain a sense of self. Illness and hospitalization can strip away one's identity, and patients may feel reduced to their diagnosis or treatment. So we can help by communicating respect and worth through speech, touch, and presence, acknowledging their roles, individuality, and life experiences, offering simple explanations before procedures, respecting privacy and autonomy. Remember, patients are people first. Their illness does not define them. Something else we can do is we'll need to work on is modifying a negative self-concept. When patients recognize that their self-concept is hindering their growth, we can use cognitive behavioral strategies, such as help them refrain from negative thoughts, identify faulty thinking patterns, encouraging positive self-talk, explore desired personal traits, and integrate them into their self-image. Other interventions could be developing positive body image, because body image disturbances require sensitive, individualized care. We can do this by supporting the patient, by allowing open expression of their feelings, validating grief and mourning stages, using play therapy with children, maybe, and encouraging self care participation, reinforcing personal strengths and decision making. Another area for intervention or implementation would be building self esteem in children and adolescents. Nurses work with families and educators, um, can also promote self esteem by encouraging positive reinforcement, teaching active listening, using language that builds self worth, and helping children meet realistic expectations, promoting feelings of success through safe challenges. If you'll take a look at box 42 3, there's some practical strategies that parents can use. We can also enhance self esteem in older adults. Remember, aging brings losses physical, emotional, and social. We offer support to older adults by respecting their intellect, culture, and their spirituality, adjusting communication for sensory or cognitive changes, encouraging storytelling and life review, advocating for needed services, and exploring the meaning of dependency and helping them adapt. Next up, we're going to look at evaluation. Nurses who are attuned to the connection between self concept and overall well being play a vital role in holistic patient care. These professionals consistently assess how the nursing care plan influences a patient's sense of self, especially when the plan includes targeted interventions for issues like body image, self esteem, role performance, and personal identity. So, effective evaluation involves both listening closely to the patient's self reports and observing behaviors that may indicate progress or ongoing challenges. The goal is to help the patient achieve key outcomes that include com- comfort with their body image and the ability to use it to meet personal social needs, a positive self description reflecting healthy self esteem, realistic role performance without excessive anxiety or fatigue, and appropriate interaction with the environment while maintaining a clear sense of personal identity. This approach not only supports emotional recovery, but also reinforces the patient's ability to engage meaningfully with their world. There's some practical examples I believe it's page 1756 through 1758, and there is where you'll see nursing care plan 42 1, which outlines care strategies for a patient, Ms. Motsky. So you might want to take a look at that. Okay, we're going to move to the next chapter, chapter 46, and this one's about sexuality. And here you have your learning objectives for this chapter. It'll help you study for your test, prepare for the exam. Sexuality is a vital part of human identity and overall well-being. It encompasses more than just sexual activity. It includes biological sex, gender identity and roles, sexual orientation, intimacy, pleasure, and reproduction. According to the World Health Organization, sexuality is expressed and experienced physically, emotionally, and mentally, and is shaped by a wide range of influence, including cultural, biological, legal, economic, religious, and historical factors. In your textbook, a definition for sexuality is offered as the behavioral expression of sexual identity. This means that how individuals respond to their own sexuality and how they interact in relationships is often learned and influenced by their environment. In clinical practice, it's essential to recognize that sexuality is deeply personal and can be reflected in a person's demeanor, communication, and physical appearance. Nurses must approach this aspect of care with sensitivity, respect, and cultural competence, ensuring the patients feel seen, heard, and supported in all dimensions of their identity. Sexual health is more than the absence of disease. It's the integration of physical, emotional, intellectual, and social aspects of sexuality in ways that enrich life, enhance communication, and deepen human connections. It plays a vital role in shaping personality and fostering love. Because sexuality is so closely tied to our sense of self, nurses must recognize and respect it as a fundamental component of overall health and well being. This means valuing each patient's sexual identity and expression and providing care that's inclusive, affirming, and culturally sensitive. As future nurses, your ability to support sexual health with compassion and professionalism will help ensure that every patient feels respected, understood, and whole. The World Health Organization offers key elements of holistic sexual health, and they say that sexual health is a dynamic and essential part of overall well being, and it includes the following critical components: well being over disease. Sexual health is not just the absence of illness, again, it's about positive, enriching experiences, respect and safety. It requires freedom from discrimination, coercion, and violence. Human rights. Sexual health is grounded in the fulfillment of a fundamental human right. Lifespan relevance. It matters at every stage of life from youth to old age, not just during reproductive years. Diverse expressions. It includes a wide range of sexualities and expressions. Influence of gender and power. Gender roles, norms, and power dynamics significantly shape sexual health. Context matters, meaning social, economic, and political environments all impact sexual well being. So, as nurses, it's essential to be skilled in recognizing and addressing issues related to these identification of problems: sexual self concept, body image, sexual identity, sexual activity, and discrimination or violence related to sexuality. By integrating these principles into care, we can provide compassionate, inclusive, and person centered support that honors the full spectrum of human dignity. So let's look at sexual identity, gender diversity, and holistic nursing care. Sexual identity is a multifaceted aspect of human identity that includes biological sex, gender identity, gender expression, and sexual orientation. Understanding these components is essential for us to provide respectful, person centered care. Biological sex refers to the chromosomal and anatomical characteristics assigned at birth, such as XX for female or XY for male. However, some individuals are born with differences in sex development, where their chromosomal or gonadal or anatomical features do not align in typical ways. These cases require sensitive multidisciplinary support and often long-term psychosexual care. Gender identity is a person's internal sense of being male, female, both, neither, or somewhere along the gender spectrum. It may or may not align with the sex assigned at birth. Gender expression is how individuals present their gender to the world through their appearance, behavior, and communication, and may vary over time. Gender diverse individuals include those who identify as non binary, genderqueer, gender fluid, or outside traditional gender norms. Some individuals experience gender dysphoria. It's a condition recognized in the DSM-5 where there's significant distress due to a mixed match between gender identity and assigned sex. However, not all transgender or gender diverse individuals experience dysphoria. Cisgender refers to individuals whose gender identity aligns with their biological sex. Transgender is an umbrella term for those gender identity or expression differs from societal expectations based on their assigned sex. Transitioning may involve hormone therapy, surgery, or both, and is often guided by established standards of care. Puberty blockers and exogenous hormones can support transgender youth in aligning their physical development with their gender identity. These interventions are generally considered safe and reversible, and surgery may be considered later with appropriate evaluation and consent. Sexual orientation refers to a person's emotional, romantic, or sexual attraction to others. Common orientations include heterosexual, which is attraction to the opposite gender, gay, lesbian, which is attraction to the same gender, bisexual attraction to more than one gender, asexual, little or no sexual attraction, and questioning, exploring or unsure of one's orientation. It's important to distinguish gender identity, who you are, from sexual orientation, who you're attracted to. Both are deeply personal and influenced by a mix of biological, psychological, and social factors. Inclusive practices nursing um, includes things like using inclusive bias free language, such as asking for their pronouns respectfully, recognizing and affirming diverse identities, rec- providing evidence based, non judgmental care, and being aware of how your communication and presence affects a person's sense of dignity and worth. These are the factors that influence human sexuality, which is complex and deeply personal, again, aspect of human identity. Sexuality is shaped by a wide range of biological, psychological, social, and cultural factors, and nurses are called to understand the influences so that we can provide compassionate, inclusive, and evidence based care. Um, One factor is developmental considerations. Sexuality involves across the lifespan from infancy through late adulthood. Each stage presents unique characteristics and needs. Infants and toddlers explore their bodies and begin forming gender identity. Children and adolescents experience curiosity, puberty, and identity formation. Adults navigate intimacy, reproduction, and aging related changes. So, nurses must tailor education and support to each developmental stage, including individuals with intellectual and developmental disabilities who may require specialized guidance and protection. Cultural and religious influence. Remember, culture shapes norms around sexual behavior, gender roles, and relationship expectations. Religion can also influence beliefs about purity, sexual expression, and morality. We must approach these topics with cultural humility and respect, while also advocating against harmful practices like female genital mutilation, which violates human rights and causes long term health consequences. Healthy sexuality requires freedom from guilt and anxiety. Nurses should support patients in exploring their values and preferences without judgment, especially when sexual practices are consensual, private, and non harmful. Another factor is lifestyle and stress. Modern life brings stressors that can impact sexual desire and satisfaction. Time constraints, work demands, emotional fatigue may reduce intimacy. Nurses can encourage couples to prioritize communication and connection to maintain healthy relationships. Another factor is menstruation and reproductive health. Understanding the menstrual cycle, including menopause and menstrual irregularities, is key to supporting reproductive health. Nurses should educate patients on hygiene, contraception, and management of conditions like PMS and PMDD, which can significantly affect quality of life. Another factor, or the last factor we're going to talk about, is the sexual response cycle. There are both physiological responses, which are similar across genders, but also emotional and psychological factors greatly influence sexual satisfaction. Four factors that affect sexuality include child-rearing considerations. Questions around fertility, contraception, pregnancy, and parenting can significantly impact sexual relationships. Issues such as infertility, same-sex parenting, reproductive choices in the age of biotechnology often require sensitive, informed nursing support. Sexually transmitted infections are common and can have serious health consequences, especially for women. Nurses play a key role in prevention, education, and counseling using tools like the CDC's 5Ps, which stands for partners, practices, protection, past STIs, and pregnancy intention, to guide sexual health assessments. Sexual dysfunction can also affect individuals of any gender, and may stem from physical, psychological, or interpersonal causes. Some common conditions include, for males, erectile dysfunction, premature or delayed ejaculation, and for females, inhibited desire, orgasmic dysfunction, dyspareunia, vaginismus, and vulvodynia. Illness, injury, and medications. Health conditions and treatments can profoundly affect sexual expression. One illness is diabetes. It can lead to erectile dysfunction and reduced arousal or orgasms in females. Cardiovascular disease and hypertension may cause anxiety or medication-related dysfunction. Cancer treatments, such as mastectomy or hysterectomy, can impact body image or intimacy. Ostomies may cause anxiety about body image and partner acceptance. Spinal cord injuries affect sexual function depending on injury level, but intimacy remains possible. Chronic pain may reduce desire, but not the need for closeness. Mental illness can disrupt sexual behavior and relationships. Medications may also affect libido. Many medications, such as antidepressants, antihypertensives, and antipsychotics, can impair sexual function. Recreational drugs and alcohol may initially enhance arousal, but often lead to long-term dysfunction. Some nursing implications include approaching sexuality with empathy, cultural sensitivity, and clinical knowledge. Open, non-judgmental communication helps patients feel safe in discussing their concerns. And by addressing sexuality as a normal part of health, nurses can support the patient in achieving well-being across the lifespan. Sexual harassment is any unwelcome behavior based on a person's sex or gender that causes distress or discomfort. It can occur in any setting and affect individuals of any age, gender, or sexual orientation. In healthcare and academic environments, recognizing and addressing harassment is essential to maintaining a safe, respectful, and ethical space for all. There are two primary forms of sexual harassment. First, quid pro quo harassment, which involves a power imbalance such as faculty over student, supervisor over employee. This occurs when sexual favors are requested in exchange for job benefits, grades, or other advantages. It's a clear abuse of power and both unethical and illegal. The second type is hostile environment harassment, which involves repeated unwanted behaviors creating an intimidating or offensive environment. It can be caused by peers or coworkers, not just those in authority. Some examples include sexual jokes or innuendos, unwelcome touching or attention, offensive images or language, persistent requests for dates, blocking movement, or invading personal space. To qualify as a hostile environment, the behavior must be unwanted, frequent, and pervasive. Effects of harassment may include victims experiencing feelings of helplessness, guilt, or worthlessness, decrease job or academic performance, loss of motivation and confidence, emotional distress, including anger and anxiety, and withdrawal from environment, such as resignation, transfer, or dropping out. Some nursing implications include future nurses and healthcare professionals recognizing the signs of harassment both in yourself and others, understanding your rights and responsibilities, fostering a culture of respect and safety, reporting inappropriate behavior through the proper channels, and supporting colleagues and patients who may be affected. Here are some recommendations for how to respond to sexual harassment in nursing practice. Again, sexual harassment, whether from patients, colleagues, or others, can be distressing and disruptive. Nurses have to be equipped with strategies to protect their well-being while maintaining professionalism and advocating for a respectful workplace. When harassment comes from a patient, nurses may experience a range of emotions from discomfort to anger. The recommended approach is to be assertive, not passive or aggressive, and includes the following steps. Be self-aware. Acknowledge your feelings. Don't minimize or ignore the impact of the behavior. Confront respectfully by providing clear, non-threatening feedback. Let the patient know which behaviors are unacceptable. You need to set limits, define reasonable boundaries, and explain the consequences if the behavior continues. Enforce boundaries by follow through with the stated limits to maintain safety and professionalism. And report the incident. Document the behavior and report it to your supervisor. Accurate records are essential. When the harassment comes from a colleague, that's workplace harassment, and it can come from peers or superiors. Employers are responsible for fostering a respectful, harassment-free environment. If you experience harassment, confront the behavior. A direct, assertive statement may stop the behavior. You want to document everything by recording dates, times, and descriptions of the incidents. You want to report it to your supervisor. You want to choose someone not involved in the harassment. You may need to escalate. If the behavior continues, file a formal grievance and seek legal advice if it's necessary. Remember, sexual harassment is illegal. You have the right to work in a safe, respectful environment and seek legal representation if your rights are violated. As nurses, you're going to play a pivotal role in shaping how patients will perceive and discuss sexuality. Your attitudes, biases, and comfort level with sexual health topics are going to be communicated not only through your words, but also through your body language, tone, and your willingness or reluctance to engage in open conversations. To effectively support patients, nurses have to develop a strong foundation in reproductive anatomy and physiology, sexual response and expression, cultural and individual variations in sexuality. Without having this knowledge, it's going to become more difficult to assess, educate, or counsel patients with sexual health concerns. Professional goals for nurses in sexual health is to promote healthy, respectful, and inclusive care. Nurses must strive to feel comfortable as sexual beings, recognizing sexuality as a natural part of life, developing self-awareness about personal beliefs and biases related to sexuality, build communication skills that encourage open, respectful dialogue with their patients, and identify and address sexual health concerns with competence and compassion. Model responsible sexual expression and respect for diverse identities and experiences. By embodying these principles, nurses can provide better care. They also become trusted advocates for the patient's holistic well-being. And just as always, we use the nursing process to determine needs and plan of care. And we do this with patients with sexual health needs as well. Nurses, again, who model healthy behaviors and possess a strong knowledge base are better equipped to assess, educate, and support patients in this sensitive area. We start the process by conducting a sexual history assessment. This should be taken for patients receiving care for pregnancy, STIs, infertility, or contraception. Patients experience sexual dysfunction and also patients with illnesses that may affect sexual functioning. There's different levels of sexual history. The level 1 is your basic history, and any nurse can take this history. Level 2 is a more detailed history, and this is usually taken by trained nurses in this type of history taking. Level 3 is a sexual problem history, and this is usually done by a sex therapist. Level 4, psychosocial history is usually done by a psychiatric nurse clinician. Best practices include ensuring privacy and non-judgmental tone, using open-ended questions and patient-preferred terminology. Normalize the conversation using phrases like, many people feel. We aim to promote sexual health, so it's recommended to use the Promoting Health 46-1 table in your book, checklist to assess personal sexual well-being and guide self-care behaviors, such as avoiding gender stereotypes, understanding biological and gender diversity, practicing safe sex, maintaining healthy, affectionate relationships. The focused assessment areas include the reproductive history, STI history, sexual dysfunction, sexual self-care behaviors, and sexual self-concept, which includes identity, body image, self-esteem, role performance, and functioning. The better model is also discussed to use for sexual assessment. It was initially developed for oncology care. This model helps guide sensitive conversations. B stands for bring up the topic. E, explain relevance to overall health. T, tell patients dysfunction is common and treatable. Also, T is for timing, address regularly. E is educate about the side effects and options. And R is record findings and interventions. Next, you will conduct a physical assessment, which would be indicated again for routine exams, STI screening, pregnancy, infertility, or abnormal findings. Patients requesting contraception or those reporting changes in urinary genital function. Nursing responsibilities include providing education and emotional support, ensuring privacy and cultural sensitivity, assisting or performing exams as appropriate. We also assess for sexual dysfunction, including for males, erectile dysfunction, which assessing for chronic illness, medications, and any psychological factors. Premature ejaculation, we explore anxiety, relationship dynamics. Delayed ejaculation, we investigate for any neurological or medication related causes. For females, we assess an inhibited desire. We assess for hormonal, psychological, or relational factors. Orgasmic dysfunction, we explore knowledge, communication, and sexual patterns. Dyspareunia, evaluate for infections, hormonal issues, or irritants. And vaginismus, assess for trauma, history, fear, or relationship concerns. The next step in the nursing process is to identify the problems or diagnosing sexual health concerns. The International Council of Nurses categorized sexual health issues into several diagnostic areas, each requiring thoughtful assessment and at times interprofessional collaboration. The first one is problematic sexual behavior. This one involves concerns about one's own sexuality, often due to behavioral issues or a lack of knowledge. It may manifest as discomfort with sexual activity or unsafe practices such as unprotected sex. The second one is impaired sexual functioning. This diagnosis applies when a person experiences changes in sexual desire, arousal, or orgasm that do not meet their needs. Causes may include medical conditions like diabetes, cardiovascular disease, medications, psychological factors such as anxiety, depression, or trauma, and relationship issues or body image concerns. Another area of problems would be victim of sexual assault recovery from sexual assault. These cases are highly individualized and may involve law enforcement, counseling, and long-term support. Recovery is nonlinear and depends on the patient's coping mechanisms and available resources. Some nursing considerations before diagnosing a sexual health issue. The nurse must thoroughly assess the situation, determine whether the issue can be addressed through the independent nursing interventions, the need for referring to a specialist such as sex therapist, psychologist, urologist when needed. Some common etiologies and related diagnoses include sexual health concerns because they often intersect with other nursing diagnoses such as anxiety related to fear of pregnancy or disease, a disturbed body image due to surgical changes or weight fluctuations, fear stemming from past trauma or an anticipated pain, grief over loss of sexual function or a partner, lack of knowledge about contraception, STIs, or anatomy, social isolation due to relationship changes or stigma. Some examples of sexual dysfunction, again, in males, erectile dysfunction, premature delayed ejaculation, and the females, inhibited desire, orgasmic dysfunction, vaginismus, and dyspareunia. The nursing role includes nurses recognizing signs and symptoms, providing empathetic evidence-based care, and making appropriate referrals, Promoting sexual health is part of the holistic well-being. The next step in the nursing process is outcome identification and planning in sexual health. Nurses play a vital role in supporting patients as they explore and express their sexuality. Recognizing sexuality as a core part of the human identity helps patients define and achieve personal goals related to their sexual well-being. Some key patient-centered outcomes include these examples, which promote sexual health and self-awareness. The patient will define their individual sexuality in a way that aligns with their identity and values. Establish open communication with significant others about sexual needs and their concerns. Develop self-awareness and body awareness, fostering confidence and comfort. Describing responsible sexual self-care practices, including identifying appropriate resources. And practice responsible sexual expression, such as consistent condom use or informed contraceptive choices. Some planning considerations. Unique outcomes must be realistic, specific, and patient-driven. As nurses, you should assess the patient's motivation, readiness, and ability to follow through. The intervention should be individualized and culturally sensitive. Nurses must ensure that the patients have access to accurate information and supportive resources. For example, rather than simply recommending birth control, the nurse should explore which method the patient is more likely to use consistently and correctly. The next step in the nursing process is implementation of the identified interventions to address problems that you have identified relating to sexuality. Some of these would include building trust and therapeutic relationships. Addressing sexuality begins with trust, and nurses must project a non-judgmental, empathetic, and respectful attitude. Patients are more likely to share intimate concerns when they feel safe and understood. We also teach about sexual health. We play a central role in educating patients about sexuality, correcting myths, and promoting body awareness. Teaching includes topics like anatomy, sexual functioning, contraception, STI prevention, and responsible sexual expression. Another area is promoting responsible sexual expression, encouraging safe practices that respect personal boundaries and prevent harm, emphasize contraceptive use, STI prevention, and comprehensive sex education over abstinence only approaches. We teach about or do interventions about contraceptive methods. So there's a wide range of behavioral barrier, hormonal, intrauterine, emergency, and permanent methods that can be discussed. We help patients choose the method based on their lifestyle, safety, effectiveness, costs, and their personal values. We also have interventions that will support special sexual needs. We should provide anticipatory guidance for patients coping with illness, disability, or treatment-related sexual changes, include partners in discussions when appropriate, and address sexual side effects of medications. There's also LGBTQIA plus health considerations. These individuals face unique health disparities due to stigma, discrimination, and lack of provider education. As nurses, we must advocate for inclusive, respectful care using correct pronouns, ensuring confidentiality. We need to advocate for patient sexuality, respecting patients as sexual beings with rights to privacy, dignity, and expression. Simple actions like closing a curtain or using a preferred name can affirm a patient's identity and comfort. We also counsel patients. Not all patients need therapy. They just may need listening with empathy. This can be therapeutic. Avoid giving personal advice or false reassurances. Instead, facilitate open, reflective dialogue. You also need to address abuse and sexual violence. We must be alert to signs of sexual abuse, rape, and human trafficking. Know your legal responsibilities, prioritize safety, and make appropriate referrals. Resources like the RAIN, RAINN, and local support services are essential tools in care. This is a helpful box from your textbook 46-3, and it is sharing information about health disparities in the LGBT population. Next, we are going to be evaluating sexual health interventions. So, evaluation is a collaborative process between the nurse and the patient to determine the effectiveness of sexual health counseling or any interventions. It involves more than observing the behavior, it requires thoughtful dialogue and reflection. Some key evaluation criteria include wellness. Has the patient's overall sense of well being improved? Have barriers such as access or disparities been addressed? Functional ability. Has sexual function such as desire, arousal, or orgasm improved or been restored? Have medical or behavioral strategies been implemented effectively? We also evaluate satisfaction with treatment. Does the patient feel the treatment was helpful? Were the patient's goals and expectations met? Does the patient feel respected, heard, and supported? Some nursing evaluation strategies include using patient feedback to assess their progress toward their outcomes, observing nonverbal cues such as increased self confidence or reduced anxiety. Use open ended questions. In what ways have you been able to achieve your goal? What methods work best for you? Or what do you think should be the next steps? Not all outcomes are going to be achieved in a single intervention. Progress may be incremental and require ongoing support. So, an important reminder is to meet clinical goals does not always mean the patient is satisfied. Always confirm with the patient whether their needs have truly been met and if further support is needed. Rest and sleep are essential for sustaining life and promoting physical, mental, and emotional well being. While often used interchangeably, rest and sleep serve distinct but complementary roles in health. Rest allows the body and mind to relax and recover without full disengagement from the environment, while sleep is a deeper, more restorative state that supports healing, memory consolidation, and immune function. Inadequate rest or sleep can negatively affect one's mental health, increasing stress, anxiety, and cognitive impairment, physiological health by weakening the immune system and disrupting metabolic processes. It can also affect emotional well being by reducing resilience and emotional regulation. Some nursing implications include that we must assess and address factors that interfere with rest and sleep, such as environmental disruptions, pain or discomfort, stress or anxiety, medication side effects, sleep disorders, and promoting rest and sleep, remember, is a key component of holistic patient centered care. And this is chapter 35, Rest and Sleep from your textbook. And here are your learning objectives for this chapter. Rest and sleep are essential components of physical, mental, and emotional well being. As nurses, we have to understand their significance and be proactive in promoting healthy rest and sleep patterns for patients across the lifespan. Rest is defined as a state of decreased activity that results in a feeling of being refreshed. This is often difficult to achieve due to modern lifestyle demands that include work, family, academics, and overstimulation. Environmental factors can also hinder rest even when time is available. As nurses, we can support rest by helping patients create a calm, restorative environment. Sleep is a state of rest marked by altered consciousness and reduced activity. Part of the sleep wake cycle, which balances energy expenditure during wakefulness with restoration during sleep, involves repeated cycles of brain and body activity, which are essential for healing and cognitive function. Though consciousness is reduced, sleep is reversible. People can be awakened by stimuli. Sleep health is a multi-dimensional concept that includes sleep duration, continuity, timing, alertness, and satisfaction. Sleep promotes overall physical and mental well-being. Some individuals sleep easily and deeply, while others struggle with falling or staying asleep, leading to fragmented or insufficient sleep. Some nursing implications include needing nurses to be vigilant in assessing sleep patterns, identifying disturbances, and promoting healthy sleep hygiene. Poor sleep can lead to serious physical and psychological consequences. Creating a restful environment and addressing barriers to sleep are key nursing responsibilities. Physiology of sleep. Sleep is regulated by two key systems in the brain stem that work together to manage the cyclic nature of sleep and wakefulness. First, you have your reticular activating system, or your RAS, which extends through the medulla, the pons, and the midbrain, and into the hypothalamus. It's composed of nerve cells and fibers that relay impulses to your cerebral cortex and the spinal cord. It's responsible for alertness and wakefulness. It's activated by stimuli from the cerebral cortex and peripheral sensory input. Examples would be pain, noise, and light. During the sleep, the RAS receives fewer stimuli, allowing the body to rest. It also includes the bulbar synchronizing region, which is located in the pons and medulla. It works with the RAS to regulate sleep cycles, facilitates reflexes, voluntary movements, and cortical activity. So, how does wakefulness occur? When sensory input, such as an alarm clock, pain, or a noise, stimulates the RAS, it activates the cerebral cortex, leading to arousal and consciousness. This system helps transition the body from sleep to wakefulness. The hypothalamus plays a central role in regulating many involuntary body functions, including the sleep wake cycle. It contains control centers that influence when we feel alert or drowsy. Damage or injury to the hypothalamus can disrupt the regulatory mechanisms, potentially leading to excessive sleep or other sleep disorders. This highlights the importance of the hypothalamus in maintaining normal sleep patterns and overall neurological health. Sleep is a complex physiological process regulated by various neurotransmitters and hormones, each playing a distinct role in either promoting wakefulness or facilitating rest. Neurotransmitters involved in sleep and wakefulness include the excitatory neurotransmitters, which are norepinephrine, acetylcholine, dopamine, serotonin, and histamine. These chemicals are primarily associated with arousal and wakefulness. Inhibitory neurotransmitters include the gamma aminobutyric acid, or GABA. GABA is essential for inhibiting neural activity, promoting relaxation and the onset of sleep. Hormonal influences also contribute. This includes melatonin, which is a hormone produced by the pineal gland. Melatonin is believed to help regulate the sleep-wake cycle and the circadian rhythms. Its release is influenced by light exposure and plays a key role in signaling the body that it's time to sleep. Other hormonal patterns, such as sleep and wake states, are also marked by distinct hormonal fluctuations that can significantly impact metabolism and glucose regulation. While research continues to uncover the full complexity of these biochemical processes, understanding the roles of these key neurotransmitters and hormones help nurses better assess and support patients with sleep disturbances. Circadian rhythms are natural internal processes that regulate biological and behavioral functions in a 24-hour cycle. These rhythms are present in humans, animals, and even plants, and are influenced by either internal mechanisms and external cues, especially light and darkness. Key characteristics of circadian rhythms include governed fluctuations in heart rate, blood pressure, body temperature, hormonal levels, metabolism, mood, and performance. Sleep is one of the most complex and essential circadian regulated processes. Controlled by a biological clock located in the hypothalamus, circadian synchronization occurs when a person's sleep-wake cycle aligns with their internal biological clock. When physiological and psychological rhythms are high, the person is typically awake. When rhythms are low, the person is asleep. Circadian disruption is also called chronodisruption, happens when normal sleep-wake patterns are disturbed. Common in night shift workers, frequent travelers, or individuals with irregular schedules. This can lead to dysynchronization, where the body attempts to sleep during peak activity times or stay awake during rest periods. Some influencing factors include light exposure, which is the most powerful external cue, occupational demands, social pressures, and lifestyle choices, which can all impact the circadian alignment. Understanding circadian rhythms helps nurses assess sleep disturbances and guide patients toward healthier sleep patterns, especially those affected by shift work or lifestyle related disruptions. Sleep is divided into two major stages. First, the non rapid eye movement, or the NREM sleep, non REM sleep, or rapid eye movement, REM sleep. These stages are studied using a polysomnogram, which includes an EEG, electroencephalograph, which is brain activity, and an EOG, which is an electrooculogram, which it looks at eye movements, an EMG, which is an electromyograph, it looks at muscle tone. Non-REM sleep, you have 75 to 80% of total sleep. Non-REM sleep consists of 4 stages, progressing from light to deep sleep. Stage 1 is about 5%, transitions between wakefulness and sleep. Light sleep, easily aroused, may experience muscle jerks. In stage 2, which is approximately 50 to 55%, is light sleep continues, still easily aroused. In stage 3, which is about 10%, you have deeper sleep begins, arousal becomes more difficult. And stage 4, which is about 10%. This is the deepest sleep, delta or slow wave sleep. Vital signs and metabolism decrease, your muscles are fully relaxed, and it's difficult to be awakened. During non-REM sleep, the parasympathetic nervous system dominates, promoting physical restoration. REM sleep accounts for 20 to 25% of total sleep, and it follows stage 2 of non-REM and cycles back to it. Dreaming occurs during this time. Dreams are vivid and often remembered. It's very difficult to arouse during REM sleep. Some physiological changes that occur during this time is increased pulse and respiratory rate, blood pressure, metabolism, and body temperature, decreased muscle tone and deep tendon reflexes. Eye movements are rapid. Small muscle twitches may also occur. REM sleep is essential for mental and emotional balance, learning, and memory consolidation. If one is deprived, the body compensates with REM rebound, increasing REM times in subsequent nights. A normal sleep cycle consists of a predictable pattern of non-REM and REM sleep that repeats throughout the night. Each cycle lasts about 90 to 110 minutes, and most people experience 4 to 5 cycles per night. Typical sleep cycle progression includes the person moving through stages 1 to 4 of non-REM sleep, then reverses stages 4, 3, 2, and instead of returning to stage 1, the person enters REM sleep. After REM, the cycle restarts at stage 2 of non-REM, continuing through deeper stages again. If a person is awakened at any point, they typically restart the cycle at stage 1 of non-REM sleep. We experience cycle changes through the night. Deep sleep, which is in stages 3 and 4, is more prominent in the first half of the night. REM sleep periods become longer as morning approaches. Light sleep, stages 1 and 2, dominates the later stages, especially if the person wakes frequently. Some clinical examples include from your textbook, the patient Charlie Bittner, which was a long-term care resident with frequent awakenings, meaning he repeatedly returned to sleep, light sleep stages, which may reduce the restorative benefits of his deeper sleep and REM sleep. There's some developmental Variation seen because sleep cycle patterns do vary by age. For instance, children experience more deep sleep. Older adults often have shorter REM periods and more fragmented sleep. This image from your textbook depicts a single normal sleep cycle in a young adult. In the normal nocturnal pattern, the shaded cycle is repeated 4 or 5 times. Periods of REM sleep generally increase in duration. Periods of deep sleep, which is stage 4, progressively decrease as morning approaches. Rest and sleep requirements across the lifespan. While individual sleep needs vary, rest and sleep are essential for maintaining physical and mental well-being. There's no universal formula for how much sleep each person needs, but general guidelines help inform care. General sleep recommendations, according to the CDC and the American Academy of Sleep Medicine, recommend infants get 12 to 16 hours a day, including naps, toddlers 11 to 14 hours a day, including naps, preschoolers 10 to 13 hours a day, including naps. School-age children 6 to 12 years, they should get 9 to 12 hours a day. Teenagers 8 to 10 hours a day. Adults 7 or more hours a day, and older adults 7 to 9 hours a day, though they may sleep less due to insomnia or medical conditions. Some key considerations include fatigue, which is a natural signal that rest is needed. While occasional fatigue is normal, chronic fatigue may indicate underlying illness. Sleep quality often changes with age. Older adults may experience lighter, more fragmented sleep. Sleep patterns are learned. Most people adapt to sleeping at night and being active during the day, but others, for instance, those that work on night shift, they can adjust to different schedules. Nurses should assess each patient's unique sleep needs and patterns and promote rest as a vital part of the holistic care. Sleep deprivation is a widespread issue with serious health consequences. According to the CDC, one-third of U.S. adults report regularly getting insufficient sleep. Many individuals live with undiagnosed sleep disturbances that gradually erode their energy, mood, and sense of self. The effects on children and adolescents include impaired growth and development, increased risk of behavioral problems and academic performance deficits. Short sleep duration is linked to childhood obesity, which may persist into adulthood. The effects on adults include obesity, sleep deprivation disrupts hormonal imbalances, including leptin, which is an appetite suppressant, decreases, while ghrelin, which is an appetite stimulant, increases, leading to overeating and reduced metabolism. Chronic health risk, increased likelihood of type 2 diabetes, hypertension, cardiovascular disease, GI issues, depression and anxiety, and substance abuse. There's some occupational and safety risk um, associated with shift work and irregular schedules that can lead to shift work sleep disorder, which contributes to fatigue, cognitive impairment, medical errors, and motor vehicle accidents. Sleep deprived individuals may have reaction times similar to those that are under the influence of alcohol. Drowsy driving is implicated in over 100,000 motor vehicle accidents annually. In one study shared in your textbook, 43% of critical care nurses reported falling asleep at a stoplight. 20% had fatigue-related accidents or near-miss accidents. Impact on healthcare workers include fatigue increases the risk of adverse events, including med errors. The Joint Commission on Healthy People 2030 emphasized the importance of addressing sleep health to improve patient safety and staff well-being. Some recommendations for healthcare facilities include assessing and adjusting work schedules to reduce fatigue, improving handoff procedures to ensure safe transitions, involve staff in schedule planning, implement a fatigue management plan, educating staff on sleep hygiene and the risk of fatigue, encouraging teamwork and support for those working extended shifts, and consider fatigue when reviewing adverse events. Clinicians, understanding what affects sleep helps us assess, educate, and intervene effectively. Some factors that affect sleep include there again developmental considerations. We've already looked at the sleep needs and patterns across the lifespans, but children, we should assess for sleepiness and short sleep patterns, again linked to obesity and other health issues. In older adults, common issues include difficulty falling asleep, frequent awakenings, and daytime napping. Chronic conditions like prostate enlargement can disrupt sleep also. Motivation. Motivation can override sleepiness. For example, excitement or engagement can keep a tired person alert. Conversely, boredom, like during an unengaging lecture, can lead to dozing off. Cultural influences. Cultural norms shape bedtime rituals, sleep environments, and expectations. Nurses have to respect and incorporate cultural preferences into care plans to promote restful sleep. Dietary habits. Tryptophan and carbohydrates can promote sleep. We recommend snacks like peanut butter toast or cheese and crackers before bed. Alcohol may induce sleep initially, but disrupts deeper stages, leading to poor sleep quality. Caffeine blocks adenosine, a sleep promoting compound, so we should avoid close to bedtime. Chocolate and energy drinks contain caffeine. Smoking, nicotine is a stimulant that disrupts sleep onset and quality. Withdrawal may temporarily worsen sleep, but long term cessation improves rest. Environmental factors, familiar environments support better sleep. Noise sensitivity varies. Some need quiet, others benefit from white noise. Hospital settings should be adapted to patient preferences whenever possible. Some psychological stress. Remember, stress reduces total sleep and the REM sleep, compounding anxiety. Illness related stress can further impair your sleep quality. Illness and sleep, such as GERD, that's your gastroesophageal reflux disorders. Those nighttime heartburn disrupt sleep. Antacids may help. Epilepsy, sleep deprivation can trigger seizures. For liver failure, causes insomnia and reverse sleep cycles. Thyroid disorders, both hypo and hyperthyroidism, affect sleep through discomfort or nervousness. ESRDs lead to poor sleep and daytime fatigue. Dialysis patients often experience restless leg syndromes. ESRD is end-stage renal disease. Medications, many drugs impact sleep. You have your antidepressants, steroids, benzodiazepines, and asthma meds included in that. Chronotherapeutics, timing medication with circadian rhythms can enhance effectiveness and reduce side effects. So examples like bronchodilators may prevent nocturnal asthma attacks. Adjusting antihypertensive timing may reduce early morning cardiac events. The most prevalent sleep disorders encountered in clinical settings, and as nurses, understanding what these conditions are is essential for accurate assessment, patient education, and effective intervention. Sleep orders not only affect rest, they impact physical health, mental health, well-being, and quality of life. Some of these include insomnia. This is difficulty falling or staying asleep despite adequate opportunity. And the prevalence affects up to 35% of U.S. adults. Risk groups include older adults, women, individuals under stress, and those with depression. Causes are the circadian rhythm disruptions, stress, pain, medications that you take maybe for hypertension or ADHD. Symptoms include daytime fatigue, irritability, poor concentration, and in older adults, delirium. Management includes non-pharmacologic Um, Interventions such as cognitive behavioral therapy, sleep hygiene, or relaxation techniques. Pharmacologic interventions are used when other methods fail. So refer to the medication guidelines. Sleep-related breathing disorders such as obstructive sleep apnea. This is recurrent collapse of the upper airway during sleep. Symptoms include loud snoring, gasping, daytime sleepiness, irritability, poor concentration. Health risks include hypertension, heart disease, strokes, and diabetes. Diagnosis is made with somnographs, ECG, oxygen saturation monitoring. Treatments include CPAP or BPAP, which is the positive airway pressure devices, oral appliances for mild cases, surgery may be considered when other treatments fail. There's also pediatric OSA, which is obstructive sleep apnea. This is caused by enlarged tonsils and adenoids, obesity, or genetic syndromes. Symptoms will be snoring, enuresis, hyperactivity. Treatment is weight loss, removal of the adenoids and tonsils, CPAP or BPAP, and corticoid steroids. Also, another problem with central disorders of hypersomnolence, idiopathic hypersomnia. Symptoms include excessive sleep despite long sleep duration, disorientation, and slow thinking. Management includes stimulants and antidepressant and lifestyle changes. Narcolepsy is another issue. This is neurologic disorder with sudden sleep episodes. Symptoms include cataplexy, hallucination, and sleep paralysis. Driving hazards and social impairment are risk. Treatments include central nervous system stimulants such as antidepressants or behavioral therapy. Circadian rhythm, sleep, wake disorders is another issue. These are defined as misalignment between internal clock and your external schedules. Common types are shift work disorders, irregular work hours disrupt sleep, jet lag, temporarily misalignment due to travel. We manage these with sleep schedules, light therapy, and behavioral adjustments. Another problem is sleep deprivation, which is inadequate quantity or quality of sleep. Causes are disorders, poor sleep habits, or hospital environment. These affect adults. You might see fatigue, impaired cognition, emotional stability. In children, you might see hyperactivity, mood swings, and attention issues. Risk include accidents, falls, impaired learning, and memory. This is the summary chart from your text of the sleep disorders. As always, we're going to use the nursing process, develop a plan of care for sleep and rest. Suggest seeing the focus assessment guide on 35 -1. As always, we start with assessment. It's important to do an assessment because, again, sleep impacts physical recovery, emotional resilience, and cognitive functioning. Fragmented or poor quality sleep can worsen illness and delay healing. So we play a key role in identifying sleep issues and advocating for better rest environments. The components of a sleep assessment include taking a patient history by asking targeted questions to uncover sleep patterns and potential disturbances. Some key questions include, do you feel you're getting enough sleep? Do you feel rested upon waking? How many hours do you sleep each night? Do you struggle to stay awake during the day? And what helps you fall asleep? If concerns arise, you want to follow up with open-ended questions to explore things like your usual sleep and wake times, bedtime rituals, sleep environment preferences, use of sleep aids such as medications or relaxation techniques, and asking about impact of sleep on their daily function. Next, you're going to complete a focused assessment by using structured questions to assess their sleep-wake patterns, changes, consistency, and duration, quality of sleep, nighttime awakenings, dreams, and restfulness. You'll look at assessing daytime functioning, fatigue, concentration, mood, and energy levels. You'll assess sleep aids or pharmacologic and non-pharmacologic methods. You'll assess sleep disturbances, and you'll find out onset causes, symptoms, severity, and coping strategies. You're going to also look for any environmental and institutional factors. Again, hospital environments often disrupt sleep due to noise, lighting, and care routines. We can advocate for quieter, more restful conditions such as small changes, um, but they can make a big difference. The patient may require further assessments, including sleep studies. Those are done by advanced practice providers, um, and which may be ordered for diagnostic purposes. The studies provide objective data to support clinical findings and guide treatment. Your role as a nurse is advocacy. So ensure you're um, incorporating patient preferences into your care plans. Educate patients on sleep hygiene and coping strategies. Collaborate with the interdisciplinary team when sleep disturbances require specialized care. Understanding a patient's sleep-wake cycle is essential for diagnosing sleep disturbances and tailoring interventions. An effective tool for doing this is the sleep diary. It's a simple, powerful method of gathering detailed personalized data over time. The purpose of the diary is to track sleep wakefulness patterns over 1 to 2 weeks. It's going to reveal behaviors, routines, environmental factors affecting sleep. It's going to help you identify trends, triggers, and potential interventions. Key components to the document include those that encourage patients to record the following daily: time of retiring and attempting to sleep, approximate time of falling asleep, awakenings during the night and time sleep resumed, morning wake up time, stressors affecting sleep, food, drink, or medications influencing your sleep with the timing, physical and mental activities. This includes type, duration, and timing. Activities 2 to 3 hours before bed, bedtime rituals, and environmental changes, worries or anxieties impacting sleep, and some benefits and considerations related to a patient keeping a sleep diary is that it's going to offer insight into their sleep quality and their quantity, can be enhanced with mobile apps for easier tracking and analysis. Bed partners may assist in documentation. It should be stress-free. If it causes anxiety or worsens sleep, then you should discontinue its use. Clinical application of a sleep diary um, is that we use the diary to support our assessment findings. We guide patient education and behavioral interventions, and we refer to tools like the National Sleep Foundation sample diary for standardized formats. Beyond history taking, physical assessment and modern tools also offer insight into our patient sleep quality. So let's look at how nurses can use observation, clinical signs, and technology to assess sleep disturbance effectively. First, physical findings can validate whether a patient is well rested or experiencing a sleep disruption. Key indicators include energy level, look for signs of fatigue, lethargy, and decreased stamina. If you want to ask about ability to perform daily activities. Next, you're going to look at facial characteristics, narrowed or glazed eyes, swollen eyelids, or lack of facial animation. Next, you're going to look at behavioral characteristics, yawning, eye rubbing, slump posture, delayed or slowed speech. You're going to also look at physical traits linked to sleep disorders like obesity, enlarged neck. These risks are risk factors for the obstructive sleep apnea, the OSA. You're going to look at for deviated nasal septum, which may contribute to breathing issues during sleep. So it's helpful to observe sleep behavior. If possible, observe the patient or gather input from a bed partner. Restlessness or frequent movement Sleep postures and comfort. Snoring may be benign or indicative of OSA if irregular or accompanied by gasping. Leg jerking, possible signs of restless leg syndrome. Some additional methods to assess include sleep clinics, which offer advanced diagnostic tools like polysomnography to monitor brain activity, breathing patterns, and oxygen levels and movements during sleep. There's mobile technology, smartphones equipped with microphones, cameras, and accelerometers can track sleep patterns. Sleep apps provide self-monitoring tools and support sleep management. While promising, many apps lack rigorous scientific validation, so you want to use these with clinical discretion. A thorough sleep assessment may reveal one or more actual potential health problems. These findings must be clearly communicated both verbally and in writing to other healthcare professionals. The written diagnosis or identification of the problem becomes a permanent part of the patient's health record, guiding care planning and interdisciplinary collaboration. Some examples of sleep related diagnoses are impaired sleep, with the etiology of emotional stress, lack of relaxation rituals, or absence of support. Signs and symptoms include difficulty falling asleep. Um, One might say they're awake for hours most nights. Persistent worry, maybe about their family, fatigue and low energy, inability to complete daily activities. Some case insight included a widow patient reporting lying awake until her teenage son returns home. She has no relaxation routine and no one to talk to about her worries, so she feels exhausted and struggles with daily tasks. Risk for impaired sleep etiology includes environmental disruptions such as shift work and poor sleep hygiene. Signs and symptoms of this problem include frequent naps and disrupted sleep cycles, difficulty falling asleep despite exhaustion, daytime sleepiness and poor concentration, emotional distress, and identity confusion. A case insight offered from your textbook was a new nurse working rotating shifts and frequent overtime reports extreme fatigue, inability to concentrate, and irregular sleep patterns. She feels disconnected from herself and seeks help. These examples illustrate how psychosocial, environmental, and occupational factors contribute to sleep disturbances. Here, I just offer you a slide of common etiologies for the nursing diagnosis that we discussed. And we did discuss these etiologies on the previous slide, but I just put it together for easy studying. We used the term sleep hygiene a few times, so let's talk about sleep hygiene. Sleep hygiene refers to behaviors and habits that influence sleep quality. As a nurse, you're going to play a vital role in helping patients adopt practices that promote restful, restorative sleep. Sleep hygiene is a set of positive behaviors supporting healthy sleep. It includes avoiding habits that interfere with sleep, such as caffeine late in the day, irregular sleep schedules. You want to encourage routines and environments that facilitate falling and staying asleep. Our nursing role in sleep hygiene is to collaborate with the patient to identify personalized strategies. We're going to provide education on establishing a consistent bedtime routine, creating a quiet, dark, and cool sleep environment, limiting screen time before bed, avoiding stimulants and heavy meals close to bedtime, engaging in relaxing activities before sleep, such as reading or meditation. Um, let's look at clinical application. Integrate sleep hygiene education into care plans. You want to use assessment findings to tailor recommendations and monitor effectiveness and adjust strategies as needed. So let's look at some nursing interventions to promote sleep. First, you want to prepare a restful environment. Ensure a clean, comfortable bed with proper body alignment. Use light blocking curtains or eye masks to reduce light. Minimize noise using earplugs, fans, or background sounds. Adjust room temperature and ventilation to patient preference. Provide thermal blankets, bed socks, or warm clothing for older adults. Some interventions to promote bedtime rituals include encouraging familiar routines such as reading, listening to soft music, light stretching or relaxation exercises, meditation or prayer, and personal hygiene, brushing your teeth or taking a warm bath. Include rituals in the care plan to maintain consistency. Um, Another intervention includes offering appropriate bedtime snacks and beverages. You can always recommend a light snack combining tryptophan and complex carbohydrates such as peanut butter toast. You want to avoid heavy spicy meals before bedtime, limit fluid intake in the evening to reduce nighttime bathroom trips. You want to avoid alcohol and caffeine 4 to 8 hours before bedtime. You want to promote relaxation and comfort. We encourage the use of non-pharmacologic methods such as back rubs, warm baths, soft music, aromatherapy, guided or visual imagery. Address pain and discomfort with appropriate interventions. Another interventions include respecting normal sleep-wake patterns by allowing patients to follow their usual sleep and nap schedules. Avoid waking patients unnecessarily, especially during their REM sleep. Help plan nap times that don't interfere with nighttime sleep. Minimize their sleep disturbances in the healthcare setting by reducing light exposure at night, maintaining brighter rooms during the day, lower volume of alarms and staff conversations, close patient doors when possible, bundle care activities to avoid multiple awakenings, schedule quiet times during the night, provide earplugs and eye mask as needed, administer pain meds as prescribed. Um, Using medications to promote sleep only when necessary. So use pharmacologic therapy only after your non-pharmacologic methods have been exhausted. Educate the patient on the medication use and side effects. Monitor for adverse effects, especially in older adults. Consider complementary therapies such as melatonin, valerian, and lemon balm. We also do interventions to teach about rest and sleep, educate on sleep hygiene, limit caffeine, alcohol, and stimulating activities in the evening, maintaining consistent sleep schedules, use the bedroom only for sleep and intimacy, avoid naps and excessive fluids before bed, creating a cool, dark, quiet sleep environment. We may also introduce um, CBT techniques like stimulus control therapy, associate bed with sleep only, sleep restriction therapy, which is limiting time in bed to actual sleep time. And that brings us to evaluation, the final step in the nursing process. Remember, when it comes to promoting rest and sleep, our goal is not to just implement interventions, but to determine whether they truly help the patient achieve restorative sleep and improve functioning. The purpose of the evaluation is to assess whether the individualized outcome in the care plan have been met, to guide our ongoing care decisions, including modifications or continuation of the intervention, and ensure that the nursing care is patient-centered and outcome-driven. Indicators that our interventions were effective include that the patient can verbalize feeling rested or have had a restful night's sleep, identifying factors that interfere with or disrupt normal sleep patterns. They use sleep promoting techniques and maintain a restful environment. They're able to concentrate and function effectively during waking hours, and the eliminate behaviors associated with sleep deprivation. Just a reminder, make sure you use these questions to check for gaps in your notes as you prepare for your upcoming exam.